Bismillah ar-Rahman ar-Rahim. Good morning, good afternoon, or good evening, depending on where you're joining us from. And welcome to this joint webinar, Hot Topics in the Diagnosis and Treatment of Hypertrophic Cardiomyopathy. My name is Firas Al-Badarian, and it is my pleasure to be your host tonight for this exciting and amazing event that we are about to start. We're thrilled to kick off 2026 with this exciting event that will focus on cutting-edge science in hypertrophic cardiomyopathy, one of the hot areas in the non-invasive field of cardiology. This event comes to you as a joint effort between the imaging working group and the heart failure working group chaired by Dr. Nadia Al-Matroushi, and under the support of Emirates Cardiac Society. We'd like to thank Emirates Cardiac Society for their support and for enabling these kinds of educational activities. So tonight's event is going to be short, but don't let this short duration fool you. The session is going to be packed with cutting-edge science, practical insight, and real-world takeaways from experts who deal with HCM on daily basis. To make this happen, we've assembled an outstanding lineup of expert speakers that will be introduced to you shortly. So stay with us, and we're about to start. Without further delay, I'm going to turn this over to my friends and colleagues, Dr. Hussam Ghalib and Dr. Nadia Al-Matroushi, who will be the co-moderators of this session. Dr. Hussam, Dr. Nadia, please take it away.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Firas Al-Badarian, and thanks to the Emirates Cardiac Society. I'm very excited to co-chair this with my dear colleague, Dr. Nadia Al-Matroushi. We will start, we'll get going so that we can have some time for some questions at the end. It's my absolute pleasure to introduce Dr. Ramzi Talabat, who is joining us from Jordan. Dr. Ramzi is an assistant professor of medicine and a pioneer of cardiomyopathy in the region, setting up multiple centers in Jordan relating to amyloidosis and hypertrophic cardiomyopathy. Today he will be talking to us about HCM, echo diagnosis, and clinical diagnosis.
Can you see my screen?
Yes, please go.
Yes, okay, so great. Firas and everyone, thank you so much for inviting me. This is it's a great pleasure for me to be here with you tonight, and I hope I'll be able to maybe shed some light on the clinical presentations of patients with hypertrophic cardiomyopathy and also the role of echocardiography. And I prepared two quick cases from our center that will highlight the value of echocardiography in diagnosing such patients. I will make the presentation as practical as I can because it'll be impossible to fully cover the clinical presentation, signs and symptoms, and also the role of echocardiography in this disease in 15 minutes. So if we want to talk about hypertrophic cardiomyopathy, it's really important to understand that it is the most commonly inherited cardiovascular disease, more common than the other ones that we talk about. And the prevalence of hypertrophic cardiomyopathy is estimated to be at around 1 in 500 population. Some estimates even throw the numbers of like 1 in 200 to 1 in 250. The major problem is that this is probably a great underestimation of the true prevalence of this disease, because it's estimated that around 86% of people with the disease are not diagnosed. And for diagnosis, the guidelines, whether we're talking about the American guidelines or the European guidelines, have set criteria for making a diagnosis. The criteria are mainly based on echocardiographic findings. So if you have a patient who has a wall thickness of more than 50 millimeters without an explanation, without the presence of a loading condition like aortic valve stenosis or uncontrolled hypertension. And there is no explanation for this increase in the wall thickness. That by itself makes that patient very likely to have a hypertrophic cardiomyopathy. And even in patients who have a positive genetic mutation or have family members with the disease, then a wall thickness of more than 13 millimeters can also be taken as indicative of the possibility of the presence of hypertrophic cardiomyopathy. It's also important to know that around half of the patients, 50% of the patients, they have genetic mutation related to the genes coding for the actin-myosin complex, most commonly the MYBPC3, sorry for the typo here, or the myosin heavy chain 7 gene. So the presence of genetic mutations is prevalent in this disease and it represents about 50% of the total number of cases. So we need also to know that, probably the audience here are maybe the majority are adult cardiologists, so they deal with adult patients, but we have to know that hypertrophic cardiomyopathy can also present in children. So the age of onset is very variable and very wide, from babies or newborns up to people over the age of 60 or 70. And sometimes the first presentation or the first diagnosis can be made at an older age. And the disease severity varies. A lot of patients can be totally asymptomatic. They go through their lives without having any symptoms, and they're just discovered by accident during a routine physical examination or assessment. But then there are patients who will have mild symptoms, and there are patients who will have severely limiting symptoms affecting their lives. So the symptomatology in these patients and then this group and in these patients is very variable. Very important, we always stress the importance of sitting with patients and spending time with them to fully understand their problems. And the way practices are set up these days, this is not always possible when it comes to the physician-patient relationship. But in this disease, just talking to the patients and listening to them and trying to comprehend what brings them or what brought them to your clinic is extremely important. And sometimes you can guess the diagnosis even before you start doing the workup. So listening to these patients is extremely important. You have to spend time with them, talk to them, understand their symptoms and analyze their complaints. The major symptoms that bring patients to the attention of us physicians include shortness of breath, which can be sometimes mild, during extreme physical exertions, but oftentimes in a lot of patients, it can be on mild exertion or even at rest. And shortness of breath can be explained by many factors. We don't have time to go over this, but shortness of breath is a prominent symptom. Chest pain as well can also be a presenting symptomatology. This could be due to increased oxygen demand because of the left ventricular hypertrophy, but also can be due to other problems, i.e. LVOT obstruction, or even in older patients with hypertrophic cardiomyopathy, it can be also a sign of the presence of an associated coronary artery disease in such patients. Syncope and presyncope also are prominent symptoms, and when we look at the causes for these, usually they are related to arrhythmia. These patients very commonly have different types of rhythm disturbances. Atrial fibrillation, for example, is very common in these patients. It may also, when it's present, it may precipitate the deterioration of such patients. But also these patients can have different types of ventricular arrhythmias, from non-sustained ventricular tachycardias to sustained ventricular tachycardias, and even to ventricular fibrillations, predisposing these patients to the feared complication of hypertrophic cardiomyopathy, and that is sudden cardiac death. Palpitations, again, is also a common symptom, and this can be due to the presence of atrial fibrillation, which can be permanent or persistent, or can be paroxysmal, and also recurrent attacks of ventricular tachycardias and whether sustained or non-sustained ventricular tachycardias. Sudden death, I put it down here because sudden death is not common in these patients, but when it happens, it really causes a lot of emotional and a lot of issues because it comes all of a sudden in a person or a patient who's otherwise healthy, and it always without any premonitory symptoms or signs. So this is the spectrum of signs or symptoms of this disease. It can be, as I said, the patient can be asymptomatic, and this is in the a big portion of these patients. So most patients, a lot of these patients, or most of these patients, will have either mild symptoms or no symptoms at all, and that's why a lot of these patients are not even discovered. They have the disease, but they're not diagnosed. But as we move to the right side, we can see that we have less common symptoms, but there are more serious symptoms affecting these patients. So that's why in our center in Al Abdali Hospital we created this sheet, and every patient that comes into the center suspected of having hypertrophic cardiomyopathy have to, when we ask our assistants to sit with these patients and talk to them, they have to ask them all of these questions in this sheet. And get their answers and just chart down their answers. This is very important because you don't want to miss any little detail that may or may not help you in getting the correct diagnosis and also trying to help these patients. Of course, after we do a full examination and a full history taking, the first thing that is done in these patients is an electrocardiogram. And the electrocardiogram can also give you some ideas about what the phenotype these patients is, because not all hypertrophic ventricles are hypertrophic cardiomyopathy. There are other diseases that mimic hypertrophic cardiomyopathy, and the ECG may be a clue to the other diagnoses. But in general, in hypertrophic cardiomyopathy, this is what you see on an ECG. You see signs of left ventricular hypertrophy with or without LV strain. So this is very suggestive of the presence of cardiac problems. One characteristic ECG is the one that you see on the screen now, where the patients will have deep inverted, symmetrically inverted deep T waves in the all across the ECG, specifically in the precordials, but also in the limb leads. And this, when we see this, this is usually an indication of the presence of apical hypertrophic cardiomyopathy, a very distinct type of hypertrophic cardiomyopathy called Yamaguchi syndrome. And the reason I'm bringing this is because we often look at this ECG, and oftentimes this leads us to do an echocardiogram because we suspect the presence of a left ventricular problem, either hypertrophy or otherwise. But then when we do an echocardiogram, in a lot of times, the echocardiogram will be interpreted as a normal echocardiogram, only because the hypertrophy is limited to the apex, which can be missed in about 40% of patients undergoing an echocardiogram. So if you see this ECG, and you send the patient for an echocardiogram, and the echocardiogram comes back negative, you should not stop at this stage. You should continue to suspect apical hypertrophic cardiomyopathy, and this patient should be sent to an MRI. And the MRI is very sensitive for this problem. Probably for us is going to talk more about the MRI, but in this condition, you can see that the hypertrophy is restricted to the apex, and you can also see the presence of an apical aneurysm, which can be a harbinger for arrhythmias, and also for thrombosis, which may cause serious problems in these patients. So seeing such an ECG in a patient, and even in the presence of an echocardiogram that is reported as normal, this should not dissuade you from the possibility that this patient might have apical hypertrophic cardiomyopathy and should pursue this with further investigations. I talked about sudden death, and I said that it's not common in patients with hypertrophic cardiomyopathy, but when it happens, it creates a lot of noise and a lot of news, because one of the causes of sudden cardiac death in athletes is actually the sudden or acute ventricular tachycardia, ventricular fibrillation. And in a lot of these patients, the underlying cause can be hypertrophic cardiomyopathy. And this study this study looks at athletes who are completely healthy, playing competitive sports, and who undergo a pre-participation ECG. And what they did is they looked at all the athletes who are completely asymptomatic, and they took the ones who had abnormal ECGs, like the two ECGs seen here in this slide. You can see these patients had T inversions, and the total number of these athletes were 155. They did echocardiography on all of them, and in 118, the echocardiogram came back normal, but in 37, they were able to diagnose cardiomyopathies based on an abnormal ECG, and in 31 of these 37, the cardiomyopathy was hypertrophic cardiomyopathy. And again, they did not stop there. They did MRIs on the 118 patients who had normal echocardiograms, and in 24, additional 24, they were able to diagnose cardiomyopathies, and in 20 out of these 24, the cardiomyopathy responsible for the ECG changes was hypertrophic cardiomyopathy. So you can see that, in routine physical examination, whether in an athlete participating in sports or in a normal person, if you detect abnormalities in the ECG, you really have to explain these changes. And your echocardiogram is your best bet to get to the diagnosis. But even in the absence of echo abnormalities, and you still suspect that there is a problem, you have to move forward and do an MRI on these patients, because with an MRI, you will pick up more cardiomyopathies and more disease causing these ECG abnormalities. So echo criteria, I talked about this. We mandate a left ventricular wall thickness of more than 50 millimeters in anyone in the absence of loading conditions, or 13 to 15 in someone with a family history of hypertrophic cardiomyopathy or genetic mutation associated with the disease. And we do the echo, to assess the presence or absence of LV hypertrophy, but also it's very critically important to distinguish the two important types of hypertrophic cardiomyopathy, whether the patient has obstructive or non-obstructive. This is an important distinction because the prognosis and also the way we treat these patients is completely different. So when we do an echocardiogram, we should not stop at a resting echocardiogram. We have to do other maneuvers to elucidate the presence or absence of LVOT obstruction. And by definition, any gradient 30 or more is considered obstruction, but an actionable obstruction is something that is as a gradient of 50 or more. Because if you have that gradient, then this patient is classified as obstructive hypertrophic cardiomyopathy. And then when we treat these patients, you will consider the either septal reduction therapies now with the myosin inhibitors, as Dr. Ahmed will probably talk about in his presentation tonight. So again, with the echo, you can either be normal or you can have obstructive or non-obstructive cardiomyopathy. So will the resting echocardiogram give me that answer? No, and I will show you in the quick two cases that I will present. If I have time for us, I will show you how to do a proper echo evaluation for these patients. So if we look at this patient, this is a 29-year-old male patient. This is from our center, who at the age of 15 started complaining of shortness of breath, which was bad enough to prevent him from participating in any sports when he was in school. At age 20, he was told of left ventricular hypertrophy. Someone did an echo and told him of that, and the thickness was reported as 14 millimeters. In October 23, he was in the hospital for a sinus nasal surgery, and during surgery, he noted to have a ventricular tachycardia episode. An EP consultant was consulted. He had a CMR, he had a 1-week Holter, and subsequently he had an ICD. So at that point, they made a diagnosis of hypertrophic cardiomyopathy, but he continued to have symptoms of exertional dyspnea in spite of the fact that he was on a beta blocker. There were no syncopes. He had 3 brothers and 2 sisters who were healthy. He was on bisoprolol 2.5 milligrams by 1. His blood pressure was okay.
Dr.
So, yes.
It's a fascinating talk, but we're getting close to time. So maybe two more minutes, maybe?
Yeah. I will just talk about this case and not talk about the other one. That would be great. So this is his echocardiogram, and if you look here, you can see that there is hypertrophy of the septum, just adjacent to the LVOT. And if you look at the mitral valve, you can see that the presence of SAM, the systolic anterior motion of the mitral valve leaflets during ventricular systole, very clear here. And also on the three-chamber view, you can see it also here. So there's definitely ventricular hypertrophy, more than 15 millimeters. I think the thickness was 18. And you can clearly see the presence of systolic anterior motion of the mitral valve. And he also had mild mitral regurgitation, is not shown here. So we did, on the resting echocardiogram, the gradient, the LVOT gradient was minimal. So there was actually 16 millimeters of mercury, which does not amount to the presence of obstruction. And we also did a Valsalva maneuver, which we routinely do on all of these patients, try to elicit obstruction. And during the Valsalva maneuver, there was also no obstruction. So would I classify this patient as non-obstructive hypertrophic cardiomyopathy, or would I go on and do other testing for this patient? So what we did for this patient, um, just one note about the Valsalva. When you do a Valsalva, you have to do a proper Valsalva. It's very difficult to, have all patients do the same effort when they do a Valsalva. And in some centers, they use this gauge, this device here, to make sure that the Valsalva that is performed is a good Valsalva. They ask the patient to blow into this manometer, and if the patient records a pressure of 40 millimeters of mercury and sustain that pressure for 10 seconds, then that is the classification of a good Valsalva. A good Valsalva will give you a better idea about the presence or absence of LVOT obstruction than a Valsalva that is done by these patients. So this patient, just to cut the story short, we did not stop at the Valsalva. We know that Valsalva was negative. We brought him back and we did an exercise stress test, which should always be done in these patients if you do not elicit a gradient on rest or with the Valsalva maneuver. He did a stress test, and on the stress test, he was able to achieve 74% of the target heart rate. He had complained of chest pain and dyspnea, and his LVOT grade was at least 74 millimeters of mercury. So he definitely had LVOT obstruction, which was seen during exercise. So the diagnosis of this patient now is obstructive hypertrophic cardiomyopathy. We discussed the options for these patients in our MDT meeting in the center, and the consensus was to go for myectomy. In Jordan, we don't have myosin inhibitors, unfortunately. So we go to septal reduction therapy between alcohol ablation and myectomy. So we picked myectomy for this patient. He actually underwent myectomy, and he's doing very well. I will not talk about this case because of lack of time, but this is interesting. This is a 9-year-old boy, and so he underwent well. Maybe I just show you this echocardiogram. This is an echocardiogram. This patient which shows massive hypertrophy. His septum was about 30 millimeters. His posterior wall was 19 millimeters. And you can see that there is a systolic anterior motion of the chordae of the anterior leaflet. It's not the leaflet itself, but the chordae of the leaflet was actually touching the interventricular septum, causing severe obstruction. We stressed this patient, and on a stress test, he had a gradient of over 120. As you can see here, it's almost 6 meters per second gradient. So he had massive gradient, and he was very symptomatic during a stress test. So we're still studying this patient. We did a DNA analysis on this patient, and we're just waiting for the results. And he's being treated now with a small dose of beta blockers. So echocardiography, and this is my last slide, is the cornerstone of imaging in patients with hypertrophic cardiomyopathy. It enables you to make a correct diagnosis. You can even characterize the phenotype of these patients. You can fully assess the LVOT obstruction, of course, if you do a full echo, including a stress test. And sometimes even you have to do a postprandial stress test. So you ask the patient to go down to the cafeteria, have a good meal, and then come back, and then you repeat the stress test with a full stomach. That sometimes can elicit the presence of LVOT obstruction. It allows you to evaluate the presence of diastolic dysfunction and also mitral valve abnormalities, which we have not discussed, but are an important component of hypertrophic cardiomyopathy, and will definitely, through all of this, will guide you through risk stratification of these patients, and also will help you in making decisions about how to treat these patients. With that, Ian, thank you so much, and I apologize if I exceeded my time.
No, thank you very much, Dr. Ramzi. It's really an hour on its own, echocardiography and hypertrophic cardiomyopathy. So we'll keep the questions to the end of the talk. So now I'm actually extremely honored and privileged to introduce Dr. Ahmed Masri. It's an honor to be in the same panel discussion with somebody who is an author of the actual clinical trials, the randomized clinical trials that have propelled this field forward. Ahmed Masri comes to us from Oregon. and he will talk to us about cardiac myosin inhibitors. Please, Ahmed, the floor is yours.
Thank you so much for the kind introduction. It's truly my pleasure being here, and always returning to join you on these initiatives. I'm sharing my slides just for the sake of time. I'm going to jump in. So these are my disclosures. And so, if you think about what's going on with HCM, we spent the last 60 decades playing outside of the sarcomere. It's a sarcomeric disease where you have excessive interactions between actin and myosin, but we always play outside. We never had any drugs that actually go to the sarcomere. Everything played outside the sarcomere. And what happens is in HCM is that you're meant to have, so in medical schools, if you've done your medical school more than 10 years ago or 5 years ago, they teach that myosin is either on state ready to bind to actin or is bound to actin. And that's the cycle. But it was discovered, 15 years ago that there is a sleepy state of myosin called the off myosin state where it's not available to engage. And normally we're supposed to be 30% in this state. So if we're resting, 30% of our myosin should be in this state. In HCM, the disordered state that happens is that you have all of your off myosins or a variable number of your off myosins shifted over to becoming ready. So these soldiers are all of them are ready to be essentially resulting in improper force generation all the time. So the patient lives with decades of improper severe hypercontractile force generation that you really don't need unless you're running from a lion or something, but otherwise you really don't need otherwise. And so I'm gonna jump quickly through some of the old stuff right now. So a lot of you, if you're keeping an eye on these things, should already have at least an idea of what's happened throughout the last 6, 7 years, where we started with the first generation CMI called mavacamten, and there were two trials, Explorer and Valor. Both of them are placebo-controlled trials, showing that you can improve exercise capacity, symptoms, reduce LVOT gradients at rest and with Valsalva, as well as reduce the need for septal reduction therapy, including myectomy or alcohol septal ablation. And so all great, correct? Like it's a very large effect size, a lot of patient response. If you use the clinical trial data from Explorer, 1/3 of the patients did not respond, but that's always funny, correct? Because in clinical trials, you don't have access to the clinical data. So you can't really judge response in a clinical trial except for certain other metrics. But in the real world, that what we see is almost 75% of the patients respond to mavacamten. So efficacy, no question, really practice changing kind of an efficacy. So how about aficamten? Aficamten is the second generation drug, and it's trialed in Sequoia, and there's another trial called Maple, I'll show you, showing similar but actually larger effect size. So larger effect size on peak VO2, on gradients, Valsalva gradients, on NYHA class and KCCQ. And so it's again, efficacy wise, there's no question that these are very, very effective drugs. However, they diverged a little bit on safety. And to understand this, you have really to do a deep dive in terms of the safety. A lot of people just do a lot of hand waving and say, "Oh, everything looks the same. I'm not worried about this," but they're actually not the same. And so for mavacamten, we used to say 5% risk of LVF less than 50% over 6 months. From Explorer, usually this is reversible. Usually it's not a big deal. However, it does cause interruptions in the conduct of the treatment for these patients. And association with heart failure is much less common. So about 1.5% of the patients over 1 year will have heart failure associated with that. Again, reversible. And then in our new study, we showed that 0.5% will have cardiogenic shock. Generally speaking, patients can be rescued from it if the team knows what to do and how to handle this. And so the typical antidote for mavacamten is dobutamine, even though your inclination is not to use dobutamine in patients with HCM usually, but this is a very good antidote for those on mavacamten who have toxicity with cardiogenic shock. What didn't come out in the publication for Explorer HCM, which should have been included, is that 13% of the patients were down titrated because of elevated drug levels. So these probably prevented these patients from going into a worse LVF and heart failure situation. And in the real life, we don't monitor these drug levels. And so that's why I like the Valor HCM data more for real life events, because Valor HCM looked at echo. They didn't look at clinical PK or drug dose levels, and showed that over 2 years you can have up to 15% EF reduction, including few cases with severe EF reduction less than 30%. So this is not to discourage anyone, but my job, I don't view it as coming to any talk and talk about how effective a drug is, if it's very effective. We've established that these drugs are very effective. Then the job becomes, well, how do I use them? What to watch for? How do I make sure that I don't end up resulting in harming any patients? And so one of the most important pieces is that you only use mavacamten, for example, commercially if available to you, for those with LVOT obstruction with leaflet SAM. That's it. You don't use it for sub-LVOT obstruction. You shouldn't be using it for mid-ventricular obstruction or apical phenotype, which we classify as non-obstructive HCM for this purpose. This resulted in an FDA approval in 2022, complicated the drug label. The idea is the FDA wanted layers to replace that drug level monitoring. So they introduced Valsalva thresholds. If you're a super responder and your Valsalva goes to below 20 millimeter mercury, then you have to down titrate the drug. You can't up titrate the drug in the first 3 months, for example. So all of these are meant to circumvent the potential toxicity from the drug. And there are obviously a lot of drug-drug interactions, which at least in the United States enforced the pharmacies to work with patients very closely to make sure they don't use drugs even over the counter, such as, for example, omeprazole or clarithromycin. If you can have it over the counter, there is a case of someone who almost died because of clarithromycin. I'll show you some pictures. But this is a step in the right direction. It's earth-shattering what's happened in HCM care in our center, for example, and many other centers, how things have shifted when we were able to offer patients mavacamten and CMIs. And the number of patients undergoing myectomy nowadays is very, very low. And so, but you have to be vigilant about this. This idea that it's only the initiation phase is the problem is actually wrong. Initiation phase, very low incidence of low LVEF, because the idea that you're going to have an acute exaggerated response to 5 milligrams or 2.5 milligrams is not true. It's actually the maintenance phase where the drug slowly is building up in your system is where, people might get more into trouble. And so never let your guard down. Doesn't matter if the patient had been on the drug for 6 months, 1 year, 2 years. You still always have to be vigilant about if they call you, they're like, I'm short of breath, my legs are swollen, or I don't feel good, or I'm dizzy, or something fun is going on. You should evaluate these patients. Also, children, like these drugs should never be around anyone who could consume them, in a weird way, because ultimately, this could result in death. And there was a kid in France who ingested a lot of the drug and died, unfortunately, despite ECMO and everything. How about aficamten? Aficamten's safety is better than mavacamten. It's about almost half the reported reductions in LVEF, one-third of the reported events in AFib, for example, and then very, very little discontinuations. Also, aficamten, you can down titrate the drug without actually having to stop it for an EF between 40 and 50%, while mavacamten, you have to stop it because it continues to build in your system even if you just down titrate. And that's where aficamten's short half-life, better PK/PD, modeling and profile helps a lot. So the FDA label for aficamten is now available. We don't have time to go through it. I'm gonna try to cut the talk short a little bit to give time for the other speaker. But it's actually much easier, more flexible, and regardless of the details, it's a vote of confidence by the FDA, who had 6 to 12 months access to every single data point in the trials, all of them essentially, to give us that vote of confidence that they feel as well as we do is that it's a safer drug. So this is just an example of someone with severe HCM, with severe LVOT obstruction, bad left atrium, heart failure, NYHA class 3, elevated NT-proBNP, where everything almost looks like it's normalizing after 2 or 3 years of treatment. So this is what's possible now. It's what never have been possible before. Obviously, not every patient response is this extreme, but this is a younger patient, and probably the younger you are, the more extreme your response will be. This is an example of someone with relatively thin septum, but really excessive mitral valve tissue and leaflet. And a reminder that the submitral valve apparatus is a modifiable structure. It's not a fixed problem. And so on aficamten, just over 12 weeks, everything looks normal now, which is great. You don't have to do anything else, no mitral valve surgery, nothing. So this is for you. I can send you the slides to refer to, but only use mavacamten commercially or CMIs if aficamten becomes available to you. In those with a gradient above 50, the mild gradient of 30 or 30 really is not sufficient of a gradient at this point unless we have a positive trial in non-obstructive HCM. It's for LVOT obstruction with SAM, not sub-LVOT obstruction. Patients should be symptomatic, and you should monitor NT-proBNP as well, because you need more than symptoms. If someone has a normal NT-proBNP, I would be worried about using mavacamten in them, because that means that the heart is compensating and the LVOT gradient you're seeing is probably just, some cosmetic issue on the echo, is not really causing them the wall stress that is required in a way almost for me to use, unless of course you can demonstrate that the patient is symptomatic with exercise or they're dizzy. Dizziness is the only exception in my book. It's not dyspnea. If you have dyspnea in an obese patient with a fully normal NT-proBNP, you have to be careful about using mavacamten. But if they're dizzy on exertion, no, that's a good reason, because they're dizzy because of the LVOT obstruction. So obviously, prior myectomy with left bundle branch block, be careful. And you have here a whole slew of other conditions that you have to be careful about. I'll finish here by saying that Maple HCM, which is showed that metoprolol is detrimental to exercise capacity. LVOT doesn't affect LVOT gradient, worsens left atrial volume index, and worsens NT-proBNP. So more about this later, but just keep in mind that we're really reinventing the whole care of HCM at this stage. Thank you.
Thank you, Dr. Ahmed, for the very nice and informative presentation. And now I would like to introduce my colleague, Dr. Faraz Badarin. He is a consultant cardiologist at Cleveland Clinic Abu Dhabi, specialized in cardiac imaging. He will discuss about the multi-modality imaging diagnosis of hypertrophic cardiomyopathy. Dr. Faraz, the floor is yours. Mute, Dr. Faraz. Can you unmute, please?
Sorry.
Yes.
Thank you, Dr. Nadia. Do you guys see my slides?
Yes.
All right. Thank you so much. My duty in the next 10 minutes is to show you how we can utilize, as an imager, how can we utilize multimodality imaging in the diagnosis and monitoring of patients with HCM. I will build up, and there will be a little bit of overlap with the talk by Dr. Ramzi. So you've heard already about HCM, and you know that grossly HCM presents as a disease where there is a significant increase in wall thickness. There is cavity obliteration. There are usually structural abnormalities in the mitral valve and the subvalvular apparatus. All of these things contribute, using the neat pathophysiological mechanism that Dr. Ahmed Masri explained, in producing the symptom complex that brings these patients to us in clinic. Grossly also, you can see foci or islands of fibrosis, and this corresponds to areas of fibrosis that are also seen on the microscopic level. And HCM is characterized by myocyte hypertrophy and myocyte disarray. I mention these things because they're important, and they have imaging corollaries that are important to identify. So in a disease like HCM, how can imaging help me? It is important when I'm suspecting the disease and I want to confirm the diagnosis. It helps me exclude phenocopies, and that's one of the most important areas, that not every thick ventricle is HCM. There are other entities that need to be excluded. It can also help me monitor response to therapy and help risk stratification, especially with conditions such as a sudden cardiac death. In HCM, there is also this unique group of patients who have a genetic abnormality without a clinically active or manifest phenotype. But that's probably beyond the scope of this presentation. If you want to look at a document that goes through the nitty-gritty of various imaging modalities in HCM, I want to draw your attention to this document, very informative one. Make sure you spend time. And what I will do is just some of the clinical pearls that I was able to get out of that document would like to share with you in the next few slides. As Dr. Ramzi mentioned, transthoracic echo is an extremely important modality. So make sure you have a good echo, you have a good quality echo, spend time on it, analyze it, because it will give you a lot of information. Show you the presence and the pattern of LVH, shows you whether there is or there isn't systolic anterior motion, gradient, the presence and mechanism of MR, and the presence of diastolic dysfunction. And also it excludes other LVH in the presence of other abnormal loading conditions, such as aortic stenosis, hypertension, or others. Pearl number 2, if you see a normal ejection fraction visually or with calculation, don't stop there. Make sure when you have a thick ventricle to incorporate myocardial deformation imaging, global longitudinal strain, because two benefits. Number one, it can help you identify subtle subclinical degrees of LV dysfunction, and can also help you identify regional abnormalities in systolic function. As you see here, areas with light shade of red correspond to areas of hypertrophy that tend to have abnormal systolic function. Even though the global function is normal, there are areas of abnormality that correspond to hypertrophy, which is commonly seen in HCM. This was also mentioned by Dr. Ramzi. If you have high suspicion and you have that the symptoms are due to HCM and LVOT obstruction, and you don't have a gradient at rest, don't stop there. Use provocative maneuvers, Valsalva, amyl nitrate, or exercise these patients, because you will be able to uncover LVOT gradient that will explain symptoms, and also direct subsequent management and referral for therapies, such as use of myosin inhibitors or referral for septal reduction therapies. This is an example of a patient who had some gradient, wasn't enough. You put them on the treadmill, and all of a sudden you're able to elicit gradients as high as 120 millimeters of mercury. Also, this is important because it has prognostic implications as well. This is a slide that I borrowed from my colleague, Dr. Hussam. It's long been shown that patients who have obstructive HCM tend to do worse compared to those who do not have underlying obstruction. So it is an actionable finding, and it helps you risk stratify your patients. So what if my transthoracic echo is not enough, not of good quality? Do you have a class 1 indication? That's another peril. You can use another imaging modality, and CMR is really another important modality in the diagnosis of HCM. When the transthoracic is inadequate, or when you have suspicion of phenocopies, such as infiltrative cardiomyopathy and others, CMR comes to the rescue and can help you differentiate these different modalities. And as I said, also can have a full hour on risk stratification, sudden cardiac death, and the role of CMR in this regard as well. Why is that? Because the image quality in CMR helps you identify more reliably the presence and pattern of LVH, and can really confirm the presence of hypertrophy, and make sure you do your measurements correctly. The panel on the right shows you different areas. You don't want to follow the red line or the orange line. You want to do something that's closer to the green line when you measure wall thickness using MRI. For the sake of time, this is just an example of common phenocopies that are important. Number one, important to exclude because they have different treatments: athletic heart, hypertensive heart disease, cardiac amyloid, and other glycogen storage diseases such as Anderson-Fabry and Danon. Each has own CMR footprint that can help you differentiate that from sarcomeric HCM. Another finding that you get in CMR is depression. And that's if you the myocyte, and this is what we likely identify with late gadolinium imaging. Are the insertion site, areas of non-subendocardial LGE that tends to keep track with areas of hypertrophy, and the presence of extensive LGE in the apical aneurysm. All of these are common patterns that can be seen in HCM. And as I mentioned, this is very important finding because it helps risk stratify patients in terms of risk of sudden cardiac death and can inform subsequent management in terms of referral for ICD implantation. And seminal work previously has shown that perhaps a cutoff or a threshold of 15% of the myocardium presence of LGE greater than that threshold identifies patients who are at high enough risk that warrants referral for subsequent consideration of ICD implantation. This was also mentioned. CMR helps you identify certain phenotypes that may not be readily available with transthoracic echo, especially if you don't have access to ultrasound enhancing agents. The presence of LV aneurysm is extremely important because it's prognostically important and it identifies a subset of patients with higher risk for subsequent arrhythmic events. So this is a patient with HCM and LV aneurysm, which is very different from patients who have mid and apical HCM without an aneurysm. And the reason the presence of aneurysm is so emphasized is because this increased risk in HCM-related adverse events, particularly arrhythmias. So by you're not only looking for more prettier images, but you're rather looking for phenotypes or patterns that can alter your management. This is just a summary. We've discussed all of these. Don't forget other imaging modalities. So for instance, patients with HCM are prone to have ischemia due to a variety of mechanisms, including number one, obstructive epicardial disease, number two, supply-demand mismatch, microvascular dysfunction. So there is a plethora of mechanisms whereby these patients can suffer from myocardial ischemia and symptoms of angina. This is an example of a patient who has apical HCM and happens to have LAD territory ischemia. The point of this slide is use your imaging modalities wisely. So can you confidently exclude epicardial disease based on this? Probably no. But you can use other modalities such as CT angiography to exclude the presence of epicardial disease. And if you do that, you can treat their underlying disease, i.e. HCM. This is another example. This is a courtesy of my colleague, Safa, where you can combine a CMR with a stress CMR to get functional and morphologic information in the same study. This is an example of a positive study, patient with perfusion abnormality that ended up with actually epicardial disease in the LAD territory. So there are different mechanisms for ischemia. Use your imaging modalities wisely and consider all of them, all of these mechanisms when you evaluate patients. So as I close, as was mentioned already, HCM is the most common monogenic cardiac disorder. It's not as rare as we think it is. Echocardiography is an essential and fundamental modality, helps you make a diagnosis, raise suspicion, and helps you categorize patients as obstructive or non-obstructive, because these are important. There are important therapy decisions based on this distinction. Cardiac MRI is a very critical modality that helps you exclude HCM mimic and helps you risk stratify patients in terms of sudden cardiac death. And lastly, myocardial ischemia is due to a variety of mechanisms. Use imaging modalities judiciously. If you think about epicardial disease, CT angiography may be helpful to exclude epicardial disease or coronary bridges that are also common. Modalities that evaluate microvascular function and vasomotor function, such as PET and CMR, can also be helpful to detect this abnormality. And with that, I close and turn it back to Dr. Hussam and Dr. Nadia.
Thank you, Dr. Faraz, and thank you for Dr. Ahmed and Dr. Ramzi. Now we'll start the questions, and please, I advise everyone, if you have any question, to type it in the Q&A section. So maybe we'll start with the first question that was asked by the audience. So how to manage a congestion in the hypertrophic cardiomyopathic patient? Maybe Dr. Ramzi, you can help us with the explaining the question or answer. Yes.
Yeah. Well, basically, you can use all the pillars of therapy that we use for patients with heart failure, in patients with hypertrophic cardiomyopathy. Now, if they don't have heart failure, which means a low ejection fraction, then you deal with them like you deal with patients with HFpEF, that because of the presence of hypertrophy and the ventricular restriction. So you can use all these medications. So you have to be very careful. When you introduce these medications, you have to introduce them in small doses. You have to be careful not to reduce the preload or the afterload in a significant way, because both of these can increase the obstruction and can cause worsening of symptoms in these patients. So if you need to use diuretics, you can use diuretics, but you have to be very careful. You have to avoid volume contraction in such patients. So you have to use small doses, and you have to carefully monitor these patients. If you want to use vasodilators, again, you have to be very careful, because the reduction in the afterload or the reduction in the preload can also cause increased symptoms. SGLT2 inhibitors may be also drugs that can be used in these patients. And actually, in non-randomized trials, in retrospective analyses of data and also from registries, SGLT2 inhibitors were effective in these patients, reducing even mortality and hospitalization in patients with hypertrophic cardiomyopathy when used. Of course, we don't have randomized trials. This will come, but so far, this is one class of medication that you can comfortably use in these patients. But again, the principle is be careful, introduce them slowly, and monitor these patients for vital signs, for any signs of deterioration in terms of blood pressure or reduction in the cardiac output in these patients.
Yeah, I totally agree with you. We have to avoid over diuresing this patient, and we have to be careful when we use any diuretics. Yeah, maybe Dr. Hussam want to.
We welcome Dr. Ahmed back. We thank him for being with us while still practicing clinical practice out in the States during this hour. So the next question that comes up and that was brought up was talking about the LGE fibrosis. So I think this question is to Dr. Faraz Al-Badarain, but anybody can jump on it. Do you go qualitatively or quantitatively with the LGE assessment when you're using cardiac MRI to make a decision about sudden cardiac death risk? And if it's quantitative, are there any specific softwares that you recommend?
Yeah, I will. So it's always better to use objective criteria. And the paper that was already mentioned, where that specifies a threshold of 15%, that was based on that analysis. But remember, this is a continuum. It doesn't mean that patients at 14% LGE have no risk of sudden cardiac death, and once they cross to 16, their risk goes up. But for these purposes, you have to draw the line somewhere. So how do we usually do it? It's better to use objective measures. Number one, to make decisions. Number two, to track progress over time. If you follow not if, you have to follow up these patients over time. When it comes to software, I'm not familiar with many softwares. The software that we use, Circle, and that's just the one we use here. I don't know if Ahmed has a different experience in the US.
Yeah, almost all of them have have the way to threshold, because this is a standard deviation based method. So really any reading software should have that. I think the challenge with the quantitative method is that you really have to be very comfortable with your MRI skills, because I see it all the time being reported as insanely high, which is almost never true. And so just be mindful that 95% of patients with HCM have LGE less than 5%. And so when you keep seeing these 20% and 30% numbers coming in radiology or cardiology like reports, most likely they're measuring the noise, not the actual signal.
Yeah, and there's also the cutoff is being changed, so there's data now showing people should maybe even drop it off to 10%, and I think that's part of the quality improvement in the MRI reading that is happening, as Ahmed had mentioned. So they have to coincide. The hypertrophy, the LG has to be in hypertrophied segments or apical aneurysm segment. So if you're calculating a high LGE in a segment that's not hypertrophied, there's either an issue with how you're doing your LGE, or you have another etiology that is contributing to it, such as concomitant coronary disease, prior infarct, or something along that nature. That's a good question.
Hassan, can I ask Ahmed a question? It was really, Ahmed, you mentioned that myosin inhibitors can better to be used when you have a gradient of 50. Does that do you refer to a resting gradient or a provoked gradient of 50 or more?
No, any gradient. I think for resting, it would be very hard to apply this threshold, but it's for any gradient. So we see a lot of patients with gradients in the 20s and the 30s. It's near impossible that the obstruction is the issue. Here, what's the issue usually is more the diastolic function, which is the problem. And as you know from Odyssey, it failed to show benefit there. So until Acacia reports out, I don't think we should be using these drugs.
Okay. So there is another question also from our fellow that what's the role of finerenone and MRA in hypertrophic obstructive cardiomyopathy? Anyone can take.
Anyone can speculate.
Yes.
This is falls in the same lines as treating using anti-failure medications. You can use them. They will help you, especially if the patient is overloaded with fluids, and if there's a component of right-sided heart failure or pulmonary hypertension, which can happen in these patients, or significant valvular disease. They improve, congestion when there's, as I said, right-sided issues. But again, you need to be careful when you introduce these medications, as when you introduce other medications. Remember, hypotension in these patients is not a good thing, because that can lead to a quick deterioration and the decompensation in these patients. So you need to maintain a good blood pressure in these patients, and anything that reduces the blood pressure has to be introduced very, 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 very carefully in these patients. So yeah, go ahead. If you think there's an indication for MRAs or finerenone, go ahead and use them. But again, because you have to use multiple medications, you really have to be extremely careful.
Yeah, I think we're going to get running out of time soon, but it's important. That message from Dr. Ramzi is really important. HCM is really a particular diagnosis, so you have to be confident in the diagnosis, and you have to be confident that this patient does have volume overload or congestion, because the symptoms of shortness of breath can be related to the gradient and not due to volume overload. So if you start going down the HFpEF volume overload, you may actually make the symptoms worse for the patient. So I think that's very important. Dr. Ahmed Masri is in and out, but there's a question, and maybe Firas or
he has to drop off. Yeah.
So there's a question about just really re-summarizing the difference between mavacamten and aficamten, open to all. The question was to all. So Ramzi, Firas, Nadia, if anybody wants to summarize it for the audience in the last 50 seconds before we run out of time.
I think from a mechanism, I'll try. I mean, Ahmed would have been an ideal person to answer this, but there are differences in the mechanism, the molecular mechanism, how they work. They both work on the myosin heads, but they have some differences between them, and they have differences as a result in pharmacokinetics and in their duration of action and half-life. From a standpoint of efficacy, they tend to be both are effective in obstructive HCM. Mavacamten was not effective in non-obstructive HCM, and there is probably some preliminary data on maybe aficamten is effective in non-HCM, but we're waiting for the randomized trials to read out. That's as far as I can tell in this space.
Probably just related to the same differences is the mavacamten, as Ahmed has clarified, is very difficult to up titrate and down titrate. It always creates problems because of the long half-life. So you start with a small dose very slowly, then you up titrate at a certain period. I don't have any experience using mavacamten because we don't have it available in Jordan yet. But you have to introduce it in small dose, in a small dose, starting dose, and then when you up titrate, you have to do it very slowly. You have to do a very slow up titration process. And an echocardiogram is mandatory during the process of escalating the therapy, because if you detect any drop in the ejection fraction to below 50%, that's an indication to stop. But then even when you stop, because of the long half-life, there are no guarantees that the ejection fraction will reverse. It may continue to drop, and that's why certain patients go into cardiogenic shock and heart failure. Aficamten does not have these problems because the half-life is shorter. So it's very easy to up titrate these patients. And if you reach a point where you need to stop or down titrate, then you can do that easily. And the drop in the ejection fraction can be reversed very quickly because of the short half-life. So that's a major advantage of aficamten over mavacamten, which I think is clinically significant, especially when both of these drugs become available to countries like ours, where patients are not very compliant with follow-up. So you give the drug to your patient, and if you're in the Gulf area or in Jordan or Saudi Arabia, that patient will take the medication, will probably leave, go to their village or to their city, and then you ask them to come back in a month, and they will never show up, and they will maybe come back after 6 months, with I don't know, deterioration or something else. So our patients are not like patients in the West, where these patients in the West are probably very compliant, with regimens and with orders. In our patients, it all depends on the weather, the availability of transportation, how they feel that day, if they have money, So I think drugs that are easier to administer to patients will be an advantage in our populations in this part of the world.
Okay. Yeah, thank you so much. I want to say one comment. I'd like to thank, I think now it's the end of the session. I would like to thank Dr. Faras and Dr. Ramzi and Dr. Ahmed. And on behalf of Emirates Cardiac Society, also would like to thank ICOM, who organized the meeting. And that's it. Yeah, Hussam, say something.
No, the fact that we ran over showcases all the excitement in this field, and we thank participants for sticking through even after the hour and for the really educated questions. Clearly, this is a very enlightened audience. Thank you very much. Wishing you a good evening, and hope to see you in a future webinar. Thank you very much.
Thank you.
Well, thank you all, and good night.
Good night.
Thank you.
Yes.